Hello, and welcome to Heat Illness and Hydration, presented by Kevin Gallinat. This lecture is approved for 1 EBP-CEU. Kevin Gallinat is a certified athletic trainer working at a busy orthopedic clinic in the South Shore. In 2017, he was the first athletic trainer hired by South Shore Orthopedics as a new position to the practice, aimed at providing better quality of care to patients. Since his hire, the practice has hired 7 more athletic trainers for use in the practice. He works in a multitude of capacities, including casting and bracing, telephone triage, medical scribe, and medical assistant. Though only working there a year and a half, he has started an athletic trainers networking program with educational talks for local athletic trainers at South Shore Orthopedics and has started a work softball league to build team cohesion. Prior to his time at SSO, Kevin served as the head athletic trainer for men's and women's track and field and men's and women's tennis from 2014 to 2017. He also served as an assistant athletic trainer for football at Boston College. At BC, he served as the sideline medical observer, or eyes in the sky, for ACC football games, home and away. He hosted as the medical director for ACC Indoor Track Championships at Reggie Lewis Athletic Center, as well as several cross-country meets of over 300 competitors. From 2013 to 2014, he worked at Bryant University with women's soccer and swimming and diving. A few interesting experiences he feels he gained a lot from include coverage of professional bull riding, research at the Corey Stringer Institute at UConn, and coverage of the 2014 Boston Marathon. Kevin earned his bachelor's degree at the University of Connecticut in athletic training in 2013, and he earned his master's degree at Boston College in sports administration and leadership in 2016. Without further ado, here's Kevin.
Thanks, Megan. Hi, everybody. My name is Kevin, as you might have heard. I am going to be presenting today on heat illness and hydration, which I think I have a pretty good background in from my undergrad at UConn, as well as in practice. Today I'm presenting for the 10th anniversary CEU celebration here at the 4 Points in Norwood. And without further ado, we'll start. A little bit about me, you've already heard. I got my athletic training bachelor's at UConn in 2013, and that's where I did a lot of my research at the Corey Stringer Institute, which is very well versed in heat and hydration research. So I was involved in a couple studies when I was in undergrad, and then I also learned a lot from the people who were teaching me. I got my master's a couple years later, and I worked at a couple different places, both clinically and in the sports setting. So I will be pulling from some of that knowledge. The reason for our discussion today is to go over the different heat illnesses and show how hydration has affected all of those categories. Today, by the end of this course, I hope that you'll be able to recognize and be able to differentiate multiple heat illnesses. Some of them are heat related and some of them are heat caused. We'll also go over how you can pick which of the measuring devices are most appropriate for each diagnosis. Sometimes you might run into an issue with accessibility to equipment, but we'll go over that in a little bit. The third reason that you guys are here today is to try to learn how to manage any heat illness in sport or heat illness in general until the transfer of care. And I think that this is one of the biggest parts that you should take in today, is that we're not necessarily going to be treating just until EMS arrives, but we're going to be treating until they truly transition care to the next person. The number 4 and number 5 are kind of the meat and potatoes of today's discussion. I want to make sure that everybody's able to, that everybody feels comfortable with the knowledge that they learned today, to be able to educate athletes and parents on the importance of hydration, and particularly how they can assess and develop a program to prevent any malhydration associated with the heat illnesses that you're going to run into in a regular clinical day. And lastly, I want you to be able to educate coaches on the Massachusetts standards. This is a legal concern that all of us face in our profession, and we need to be able to explain that to coaches and be able to prevent and manage the heat illness when it comes up. And everybody should be on board, not just the athletes, but also the coaches and parents. And this one's important for our legal standing. Today, we're going to, the reason that we're here is to maintain our education, to continue any new information that you might be able to build on from your undergraduate education or whatever you might know. There's been some new information in the last 10 years. So we definitely need to cover that. We need to go back to all of the recommendations that the NATA set out for us, because this is what our professional organization has set forth as the best practice. And we need to make sure that we're standing with and in line with all of the other athletic trainers in the nation. And we also, from a state regulatory standpoint, we need to make sure that we're in compliance with the state regulations, because otherwise we might lose our license.
I am not biased. I'm just kidding. I am not biased. I don't have any financial kickbacks for doing this type of presentation or research. I want everybody to know that I am just looking out for the athlete, and I am not invested in any devices or any companies that would be doing any of this research. Today's ideas are my own, and it's my own interpretation of other people's research. And I guess I could say that I'm a little bit biased because I worked at Torres Stringer Institute in my undergrad, and I might have a little bit of influence from their ideas, but none of this research is actually my own, and it's today just what I think is the best information for athletic training to use. So we're going to start to go over exertional heat illness. I think if you guys just want to read this slide for a second, it's a little bit of a narrative. It'll take about 30 seconds. So we're going to start off by just going over the physiology of exercise and what happens when we are exercising in the heat. When we start to exercise, our blood flows and it goes to the muscles that we're trying to use to do that sport. If you're running, then it primarily goes to the quads and the hamstrings. You're using a little bit in your core, but I guess you could use some in your arm swings. But for the most part, you're trying to get the blood to the peripheral system rather than the core areas of function. So it's interesting to talk about the way that the blood is preferentialized by the body. First, it's going to make sure that it has the essential blood going to the brain. That's the number one thing for the human body to need on a regular basis. If you don't have oxygen in your brain, then you're not going to be able to do anything. Then you need to make sure that it's in the heart and lungs. It then will allocate to the sweat glands and to the peripheral of the skin to make sure that you're thermally regulated. And finally, it will go to the working muscles. So if you look to the left of the slide, core body temperature is the driving factor in thermal regulation. Your body recognizes that it gets a little bit hotter and it tries to do things to cool itself down. If that pathway is blocked, then you're not really going to be able to cool yourself the way that you want to, and your body temperature actually starts to heat up more. So we've noticed that through the evaporation, that's the main way that your body's going to dispel heat. If the ambient temperature of your environment is higher than what your body is, then you're not necessarily going to be expelling any heat. You're going to be taking on heat from your environment. So if in situations where you're in a heated environment, you're not going to be able to thermoregulate, and your body's going to have to find other ways to get around it. But sometimes you're still exercising through the heat in an athlete, and you won't necessarily be able to stop the thermoregulatory issues. So you can't stop exercising if you're in the middle of the game, you're just gonna keep exercising. So we have to figure out ways that we can stop the overheating from happening. Evaporation dispels about 580 kilocalories of energy. So if you have 1 kilogram loss of sweat, then that is the main source. But we've noticed that if you're not necessarily able to dispel all of that through evaporation, then your body can start to decrease in performance, and that's where it comes in for athletes. So the first thing to be decreased is performance, and that's the best way that you can get through to athletes, that you can see it every day without actually having the whole body issues that you might experience. As in this slide, you can kind of see that the evaporation is the main thing, but if the ambient temperature is higher and you can't dispel that heat, then you're not going to be able to get rid of it because water just slides off and all you do is lose water. So if you can't thermoregulate, there are a bunch of illnesses that you will experience. The top 4 are strictly related to heat regulation, whereas the bottom 2 are more of a brain chemistry or blood chemistry deal. So the first thing that you're going to try to differentiate is if it's a whole body issue or if it's a local issue. The first thing we're going to talk about is heat cramps, and we'll talk about exertional sickling, the heat exhaustion, heat stroke. I'm sure that all of you are familiar with, and then hyponatremia. There are some minor differences between the 2 types, and we have to discuss those. The differentiation I'm going to loosely go over right now, and then we'll go in a little bit greater detail. You want to make sure that for heat cramps and heat and exertional sickling, that you're differentiating the location of the symptoms. And if they have a prior history, then that can play into it. If they have a history of sickle cell trait, then that's obviously a dead giveaway that you have to pay more attention to that athlete. I'm sure that you're all aware. But the localized cramping is different than the whole body cramping, and that's what you have to recognize. Heat syncope is the mildest form of heat illness. Heat exhaustion is a little bit more body issue than just a temporary state. And then the heat stroke is the most severe of all the heat illnesses, and that one is the one that you need to know for sure in order to make sure that an athlete survives and that they stay safe in the sport. Hyponatremia can be 2 different directions, and there's a difference between the type of water balance that you have if it's high or low in your body. So exertional sickling, I'm sure that you're all familiar with the term, and it's one of the things that we need to be able to recognize through your prior medical history. You should be able to tell if somebody has sickle cell trait, and if they haven't been tested, that's a little bit of a discrepancy of policy. Some people test, some people don't. If you happen to know, then that would help significantly, but if you don't know, then you have to be able to recognize the symptoms. Exertional sickling happens to start off because of 4 different reasons. There has to be a chemistry inside of your blood in order for these cells to turn from the regular round shape to the sickle cell shape that you know. There would be a state of hypoxemia, meaning that there's low oxygen. There's a little bit of a more acidic environment in your blood. There could be a high concentration of blood cells in a certain area versus the normal balance. And then dehydration or lack of water inside of the blood is the final step. So if all of those categories are present, then you're not going to be able to control in any way, shape, or form this process, but your blood cells can start to sickle. In sport specifically, this is going to be coming from a decrease in O2 because it's all going to the rest of your cells instead, the rest of your peripheral cells instead of necessarily everywhere else in the body. So you're either going to have too little red blood cells in the body. That would be lower increase or lower oxygen. You could have a lower concentration of the blood cells in a certain area, and that would start the sickling process, and then you could cascade from that point forward. Or you could potentially have less blood volume in general. pH decreases can happen in the sport. You can think about that happening every time that you develop lactic acid from the muscles. So the further that you get into a sport, the more likely that you potentially could be making an acidic environment in the blood. And then if you have too much blood rushing to the periphery, then you won't necessarily be able to control how much is going to the central organs. So while heat cramps are a localized imbalance of sodium, most of the time it's related to a sodium imbalance. There can be fatigue issues that cause the heat cramps, or cause cramping in general, but the heat cramps are due to a dehydration usually, and that increases the amount of sodium. If you have too much sweat loss, then that can be a sodium imbalance in that direction. And that can be very easily treated. I think that you're all aware that you can just, most of the time, remove the athlete from the activity, start to do some stretching to try to help with the muscle itself. Most of the time, it's going to be in the calves or in the quads. Hamstrings are also a culprit most of the time in running athletes. But then you want to try to help the patient replenish their sodium. So you'll start to give them either a sodium packet, or you can give them some Gatorade. Usually a sodium packet in Gatorade would be the best, but you can also start to give them some pickle juice, or some people use mustard. Exertional sickling is a whole body episode where it's not just a localized area that's cramping, it's the entire body. So you have to recognize that it's not just one area. And the first thing that you want to say to the athlete is that you need to tell me where you're feeling the pain. If it's just in one body area, then I wouldn't be as concerned. But if it's feeling of lethargy, of slowness all over the body, not being able to contract multiple muscle groups, or sometimes people feel like a wrenching pain inside of their stomach as well as everywhere else in their body, and that's kind of more of that giveaway that you feel the convulsions of the stomach. So want to look out for that. If it's untreated, this is a medical emergency. So if it's untreated, the patient definitely could pass away, and that's a serious reality that you have to come to. It'll start the process of rhabdomyolysis, which is the breakdown of muscles, and at the longer that the patient is experiencing these symptoms, the more that they're going to have issues, whole body and system shutdown, rather than just in the areas that they can currently expect is feel like pain. So you want to try to activate EMS immediately, remove from activity, administer oxygen, which we can't do, and start to cool if you can. So the oxygen is really what the biggest thing for exertional sickling you need to do, and most of the time that will be coming from the EMTs. The next topic would be the true heat illness rather than a sickle cell trait disorder. So heat syncope is a pretty easy thing to understand. If your body starts to put more blood into your peripheral muscles, you're going to start to get less oxygen going to the brain because it's allocating all of the blood to that area. So if you start to get too much blood in your periphery, your body will just automatically tell you to fall to the ground, and that will start to get the blood flowing back to your brain and stop those muscles from doing anything. So in this particular case, the biggest issue is that you have to find that they're not having any issues with their brain, not having issues with confusion or dizziness that lasts longer than a couple minutes. It's not a medical emergency as long as they can come to relatively quickly after they fall. Most people will be a little bit out of it, and within 2 or 3 minutes they'll come back to being their normal selves. So with heat syncope, it's not a medical emergency. You just want to get blood coming back to the brain. Heat exhaustion is more of a state that the patient has gotten into over a period of time. And it can be from multiple practices. If you have a 2-a-days, the first practice might feel fine, and then the second one you're going to feel that you're a little bit slower, which every single athlete is going to feel anyway. So it's a little bit harder to see it coming, but once you start to notice that the patient has a little bit of minor cognitive changes, the loss of energy is the same. With the cognitive changes, it's going to happen over time, and you might notice it at a certain point or a certain drill. during the practice. It's not going to be something that hits you right away, but they might over time start to get slower. So you want to recognize that they're starting to have trouble in practice, and ideally you would want to try to collect rectal temperature. Most people, there's a little bit of pushback from athletes when you're in heat exhaustion. Most people would voluntarily not want to have something inserted into their body, so the less invasive would be preferred for the athlete, but if you can, rectal temp or a thermostat will be great. But if you can't, then you just want to try to get the patient to remove themselves from activity, and they'll start to cool down on their own. You want to elevate the legs so that you can get blood flowing back to the body instead of, back to the heart and back to the brain rather than collecting in the extremities. And then you want to remove them from play and move to the shade and drink fluids. I think everybody knows this stuff. But the defining trait would be temperature less than 40.5 degrees Celsius or 105. If you can't collect this temperature, then you have to do the things that you want to minimize the next thing. So you kind of treat the same, but without major cognitive changes, you'd be a little less concerned of heat stroke. I think one of the big things that you want to focus on when you're looking at these injuries is that they're not a continuum. So if you have a heat exhaustion that doesn't always lead to exertional heat stroke, they're kind of different. Heat stroke is once you get up to 105. And 105 isn't always something that you're going to notice as a patient. You're going to notice it after they fall and after they have all of the cognitive issues as well. As a patient, you might notice that you start feeling lethargic to begin with, and that you might have some issues with tasting more sweat, like feeling more sweat on the outside of your body. You might have a thirst in your mouth, but you can still be exercising past 105 degrees and still be awake and still be doing things and still push yourself past that point. So heat exhaustion is really just feeling those symptoms with the absence of the temperature being higher than 105. I was involved in a study where I was doing the exercise, and in undergrad, it was another thing at the KSI Heat Lab, where I was inside of that football equipment and I was exercising. I had a rectal thermometer, and so they were monitoring the entire time. And it was primarily doing cognitive things, like there would be a flash on the screen of a green light, and I'd have to jump onto this side when I saw that green light, and then I'd have to go to the other side when there was another green light. So they were measuring cognitive issues. But during that study, I got above 104. And they stopped the study once you get to 104 and a half. So I got above 104. They started to talk to me the entire time. I was feeling fine. I might have felt like I was a little bit hot, but who isn't inside football pads in a heated room at 90 degrees? So I tried to keep going, and they told me that I had to stop at 104 and a half. And that was just below the threshold of getting to the heat stroke. So they had to stop for the sake of the study and make sure that I was safe, but I felt fine. They put me into the cold tub, and I felt great in the cold tub. I wasn't feeling too cold. It's not like the actual temperature of the water matters. It's just that your body's expelling so much heat that you need it to stop. You need to somehow get that heat away from your body, and it felt good to me. And once I got down to a temperature, then I felt cold, and I started shaking. We'll go over that in a second. But the biggest issue is that the longer that you're above 105, the less of a chance of survival you have. So you need to get that patient down below 105 before they have any of the issues that come with lipid destruction of the cell membranes, issues with the actual membranes themselves exploding and then causing a bad toxic environment for all the rest of the tissues inside of the blood. The hardest part is that most people don't want to do the temperatures, the temperature devices that you actually need to use. So you have to use the rectal thermometer, and that's the gold standard. Once you have decided whether you're going to use the rectal thermometer or something else, you need to know whether that's going to be a valid device. And if it's not valid, what you can do to overshoot it and make sure that you're keeping the patient safe. So in my experience, when I didn't see any of these warning signs, I might have had the red sweaty skin and a little bit of loss of cognitive function where I was going from side to side, and I didn't go as fast as I did at the beginning, but I was perfectly fine underneath 105. If I had kept going, I probably would have had some whole body weakness, dizziness, nausea, all the telltale signs that you know about, and I didn't actually collapse. So the lack of collapse is awesome. But if an athlete falls, you need to know that if they're cognitively altered, then they're not going to be able to tell you if they're feeling lethargic, or they're not going to be able to tell you that they're feeling dizzy. They might just be in a fog, and you need to try to get them as soon as you know that there might be an issue greater than regular heat exhaustion. You want to try to get them into a cold tub as soon as humanly possible. The other types, besides rectal temperature, the other types of devices that you can use are okay. Oral, there are two orals here. The oral, as in your ears, is a little bit better than tympanic and axillary. The oral in your mouth and oral in your ears is a little bit better than those other three. The mouth oral is better than oral in your ears, tympanic, or axillary, and the temporal one is absolutely useless according to it. So if you're using one of those other devices and it seems like it's starting to get near 105, I probably wouldn't even guess. I would just throw them into the tub. At least you need to remove them from activity, get them into some type of a cooler environment that doesn't have any heat, and you need to try to get them to cool down as fast as humanly possible because it might be higher than what your temperature device is actually reading. The last one is the ingestible thermistor, and I put that at the top. I didn't talk about it because that's the best one. That's a pill that you can swallow, and it'll be inside of your organs. So it actually knows your true core body temperature, but it's very impractical because I think that it costs about $1,000. So if it's a one-time use, that probably isn't very realistic for most places, and it's good for research. But most people, if you're just going to excrete it a little bit later that day, and it takes 5 hours to actually get the right temperature for that exercise, it's not really realistic. So I put that on there, but I don't think that it's realistic. So I'm not going to talk about it much more. We're going to go into the next thing that has similar issues with cognitive problems, because this is a brain chemistry thing. Just like it's a brain chemistry thing with your heat illnesses at some point, but this really starts from the chemistry of your blood, rather than hyperthermia, which starts from temperature regulation being the issue. Hyponatremia also has altered mental status, muscular weakness, the dizziness, disorientation. Seizures are noted as a potential side effect of hyponatremia, so that I guess could be a differentiating factor, but not every person who has hyponatremia goes with a seizure, so that's not a deciding factor. Well, hyponatremia is the lack of concentration or osmolality of sodium inside of your blood. It's diagnosed when you get to 135 millimoles per liter, which I know all of you talk about every day. So that's just an assessment of the levels of sodium inside your blood. And sometimes you can notice those blood levels below the clinical diagnosis, and you might not still see the symptoms. So that you have to recognize the symptoms when they happen, because every time that they happen, that means that you're already at the level. You could potentially have a lower serum sodium level, but not see the results, but not see the signs. But as soon as you see those signs, you need to know. Emergency and feeling the actual symptoms is below 130 millimoles. So getting those measurements is usually not something that's realistic for a regular person, but you have to understand the background to it. If your sodium is too low inside of your blood, you're not really able to exchange all of the sodium that you need in your body to make the synapses happen. So in your blood, in your brain, you need all of that sodium transferring back and forth in order to make any type of thought, any type of motion. If that's starting to go down, you're going to see differences in the body, whole body, all around. So in this instance, when we go back to hypothermia, your body is having trouble thermoregulating, and it'll start to break down the barriers of all of your membranes. So you'll start to get an altered chemistry coming from the higher temperature. But in hyponatremia, there's something that's causing your sodium to be lower inside of your blood. And most of the time it's because of drinking habits. The two different types of hyponatremia are hypovolemic and hypervolemic. Most people think about hyponatremia as being the one where you drink too much water in a day. And the college parties that you've heard about where people die where they're drinking gallons and gallons of water. That's the type of deal that most people know about. But you can also have hypovolemic hyponatremia, which is where you have a chronic sodium depletion. And when this happens, it's not something that you would have picked up on easily. It's something where over the last 2 to 3 weeks, maybe month of training, this athlete hasn't ingested the right amount of sodium to keep those levels up. And on any given day, they didn't drink enough water and they're already depleted. So they're not, the volume of their blood is starting to drop. And the volume of their blood dropping means that they're not able to get enough oxygen to the brain because their volume is dropping and then the amount of oxygen that it can get to the brain is also dropping. If you haven't had that much water and you're feeling thirsty, that's kind of a good way to diagnose over the athlete. It's difficult to differentiate between hyponatremia and hyperthermia in an athlete because they exhibit the exact same symptoms, but you can't do a blood test on the field. So the first thing that you have to try to do is ask them questions, and they might be a little bit disoriented. If you're trying to decide between hyponatremia and hypothermia, I would try to cool as much as possible first, because that's a little bit more of a controllable thing that you can do as a clinician. You can also start to activate EMS, which you should have done at the very beginning when you were finding any of these issues. But when they get there, they might be able to test the blood osmolality. So going to the treatment, we already talked about it a little bit, but the evidence behind it shows that the faster that you get the patient into the water and the faster that you get them to drop their activities, the better they're going to be overall if they have a heat stroke. If they have hyponatremia, they probably also need to be cooling a little bit because they need to stop all of the activity that might be using more sodium or might be creating a higher perspiration rate getting rid of that. So for the removal from activity for both of them is the first step. If you can administer a saline, that would be great for hyponatremia, but we can't really do that. We don't have IVs on a regular basis and an IV push. So for hyponatremia, the first thing that you need to do is remove them from activity. The second thing that you need to do is get help from somebody else. You're going to call EMS and they're going to arrive and they're going to start to do all the things that they need to do to get fluid coming back. If hyponatremia is hypovolemic, then you're going to try to get a hypertonic solution in. If it's hypovolemic or hypervolemic, then you're going to get a hypotonic solution because you want to try to get that balance. So you need to do the opposite of what the issue is. For exertional heat stroke, you need to get them into the water as soon as humanly possible. And there's a difference in the cooling rate based on which type of coolant, what the temperature of the water is, what types of things you're doing inside of the water. If there's ambient temperature is higher, then it's going to be a little bit lower. But if you can get the patient all the way into the water, then it's going to be better than if some of their body is sticking out. So there's a couple techniques that you can do for cold water immersion that change that. The best possible temperature that you can do is 33 degrees, which isn't, or sorry, 35 degrees, which is pretty unattainable in the field. I don't know how many people can constantly pour ice into the water while they're at a practice, but if you can try to get it down to 55 degrees, that would be the ideal situation. If you do cold water immersion, you're transferring heat at about 40 times faster than if you're just doing cold towels. And that's because of convection. We're trying to do all of our heat dispelment on a regular basis through evaporation, but in a higher temperature, you can't do that because it doesn't actually evaporate. It just goes right, sloughs right off of the body. When you transfer into the cold water itself is taking on the temperature of your body. So it's constantly trying to absorb the heat that you're dispelling. And if you can start to put a little bit of motion into the water and agitate the water, then it helps with the flow, so you don't actually end up making that little bit of a circle around your body with that extra barrier that people sometimes report. If you have stagnant water, then the water right around the edge of your skin turns a little bit warmer, but then it doesn't dispel and switch to the cold water. There's a little bit of a film. So you want to make sure that you're constantly circulating, and that'll help out with convection. Or conduction, sorry. An interesting fact is that from 1975 to 1990, there were absolutely no deaths using cold water immersion in a study done by Dr. Casa. There's also some good evidence saying that ice towels don't really do too much. They can be helpful, but you have to put them in certain areas on your body. So if you can do the cold water immersion, that does everything all at the same time. So I'm not going to say that ice towels or removing people from activity isn't helpful. It is helpful, but it doesn't do the cooling rate the way that you need to in order to minimize chances of death or other associated issues. The last one is IVs. Some people try to treat with IVs and think that if you put cold water into the body, that's going to help. I guess it can help, but it's not really a benefit compared to the normal oral intake. So drinking water is the same as using IVs. So there's no need to put patients through the IV when they're already cognitively disoriented. So we'll move on to hydration status, which I think is probably one of the biggest ways to prevent heat illness. Patients can be in a hypo, hyper, or euhydrated state, and most people are when they walk into practice, they're underhydrated. That puts the patient at a less of a chance of being able to perspire the amount of water that they need to cool themselves off to eventually evaporate. It decreases blood volume, so that means that your body is working a little bit harder to get the same amount of oxygen to its muscles. And when it works harder, then it creates more heat, which then feeds back into the higher body temperature. When you have decreased blood volume, the stroke, this is just the heart stuff surrounding the lower amount of water in your blood. If the stroke volume goes down, and so does the cardiac output. Cardiac output means that the muscles are getting less blood, and so then you have to increase the heart rate. The more that your muscles have to work, you also create that acidic environment. And so hydration is really important because it can help with all of the things for heat illness, including exertional sickling. That lactic acid is a buildup of acid inside of your blood coming from your muscles, and if you can do anything to minimize that as a risk factor for exertional sickling, there's no reason not to hydrate. So we're going to go into hydration for a couple minutes. Hydrating an athlete means that you're putting the body at its optimal position to function as it's supposed to. Your heart is supposed to have a little bit more of an easier time when it's trying to pump the blood through by having the correct volume inside of the blood itself. You want to make sure that you can perspire, and you want to make sure that all the muscles themselves have all the water that they need to perform the activities. So if those are down, even just 2%, there's been a couple studies, and one of them was done by Will Adams. I don't have that one really on my list, but I'll the references at the end. But Will Adams did a study from the Corey Stringer Institute that showed that a 2% drop in heart rate, 2% drop in hydration, body weight will decrease heart rate. A 2% body weight drop will also increase your temperature by 2 degrees Celsius, and it can decrease performance by 5%. So hypohydration is the main issue. Hyperhydration for hydration status, and not just specifically relating to hyponatremia, actually doesn't have an advantage for thermal regulation. So if thermal regulation is causing all of these other issues, then maybe you don't need to do something that's not going to help with thermal regulatory issues. And if it's also going to cause you, if it's also going to cause hyponatremia, then that's doing more harm than good to be overhydrated. So I would encourage athletes to try to keep their hydration status right exactly where it is, and that's what euhydration is. So in order to keep euhydration, you want to develop, as mentioned in the 2017 NCAA guidelines, we want to develop a fluid replacement plan for athletes. And the fluid replacement plan is something that is individualized. So we'll go over that in a couple minutes. But not everybody's the same, and some of that comes from the sweat rate that I'm going to talk about. Some of it comes from the fact that people don't necessarily drink the same. And some people like to drink in spurts, some people like to drink all at once, some people drink throughout the entire day. And other people, there are differences in thirst. So you really need to make sure that you're tailoring your fluid replacement plans, whatever your athlete requires as an athlete and as a person. In order to develop this fluid replacement plan, the best thing that you can do to start is to calculate the sweat rate. And everybody can very easily calculate the sweat rate. The amount of water that you lose while you're exercising is the amount that hopefully you're drinking in the athlete. So if you lose about 1 kilogram of weight, that equals, conveniently due to the metric system, 1 liter of water. So if you start to weigh yourself before and after, you can find the amount of water that you lost in your body. You have to keep in mind that you're drinking fluids hopefully throughout the practice or the event. And then you also are, at some points in time, also going to the bathroom. So you might have to account for those. If you can create a setting where you're taking a sweat rate under the exact same conditions as what you're going to be performing, then you're going to know the types of factors that you're experiencing are included in your sweat rate. Your sweat rate will change based on a bunch of different factors of your training, but also depends on whether you're able to control the other differences between yourself. It's worth noting that other people are different than yourself, so one athlete might be different than another in different ways, so you can't just make one blanket statement going across your teams. They have to be individualized. Once you take your body weight, new is best. You want to make sure that if you're taking the body weight, then you're incorporating all of the loss of sweat through your clothing. So if you're wearing clothing, if you wear the clothing to begin with, it's dry, then you sweat, and you're wearing the clothing when you take the second measurement, you're still including the weight of the water that's going into the clothing. So if you can do it that new, that would be the best, but if not, there might be some way that you can calculate the weight of the clothing beforehand and the weight of the clothing afterwards. So try to minimize the athlete from actually going to the bathroom, and then measure out a certain amount of water if they're having the water on them, and tell them that for this half-hour period or for this hour period, then you're just going to try to control how much you're using. You want to try to replace about 2/3 of whatever you're losing in the exercise while you're exercising, and then later you can replace after the activity is done. And some of that is coming from your body's only able to handle about 1.2 liters per hour of water. And then you want at the very end, if you can calculate the sodium loss, then that would be ideal. But I would just try to employ most people. If you're a salty sweater, if you feel on salt, just putting a little bit of electrolytes in afterwards. This fluid replacement plan will be specific to each person, and I'm going to go over the factors that change so that you guys can kind of try to incorporate that into your everyday life with athletes. But the other methods that you might use to replace fluid, which isn't necessarily recommended, are drinking ad libitum, which means drinking at free will. Some people don't drink even if they're thirsty, so you can't really use that as a best practice. Drinking to thirst sounded like it could offer a little bit of an advantage, because then you wouldn't necessarily have to calculate all these things, and athletes don't like drinking, they like to just do what they feel. So it sounds good to drink to thirst, but there are differences in the way that you ingest fluid, and some people can feel thirsty before others. They might have a higher or lower threshold for feeling thirst. Most people across the board, through a lot of studies, have shown that if you take one sip of water, regardless of the concentration of sodium in that sip of water, it can quench your thirst at just 200 milliliters of water. So taking one little sip of Gatorade could feel the same as taking a sip of water. And if you're already low on water but high on salt, then that could be doing the opposite of what you want to do. Later on, we'll talk about the inter and intrapersonal differences. And again, that means that each person has a different rate of loss of water and a different rate of loss of sweat. Other considerations, acclimatization will matter for the athlete. So if they're unacclimatized and you take a sweat rate at the beginning of the season and then you take a sweat rate in the middle of the season, it'll be different because the patient has already acclimatized and they figured out all the ways to train and regulate. You want to make sure that you know about the dynamics of the sport. So if you're doing your sweat rate calculation, you want to make sure that you're going to be doing activities that are similar to what they do when they compete. If you're an endurance athlete, for instance, you can't just do a sprint workout and expect that sweat rate is going to be the same as the endurance activity. Length of time, playing surface, if you're on a hot field, that's going to be different than if you're over a body of water. Some people won't have access to a water supply if they're exercising, football players and basketball players. A lot of times some will vary much differently between players because some stay on the field or the court for longer than others. For the most part, soccer, you can kind of calculate because people know how much they're going in and out. But if there's a lot of substitutions, that makes a difference. Thirst, as we talked about, is not a good indicator, and the plasma osmolality of your blood actually changes faster than thirst. So in addition to thirst not being reliable, you also don't know if the thirst by itself, even if you know that your thirst indicates at a certain level, the plasma osmolality will change first, and then you'll see a delayed response. And thirst isn't only good really through the literature at rest. So intensity is just shot at one. Other factors would be baseline hydration status over the last week, nutrition, medications, bathroom breaks available during the activity. If you can minimize your body weight loss to less than 2%, that's ideal. In order to figure out how you're sweating and how much you're losing, you can try to do the sweat rate, but you don't necessarily know anything about your baseline status. So we need to try to educate athletes to use a couple different devices. The first, for temperature, like we said earlier, we kind of already covered those, so I'm not going to cover those again. But the hydration status we haven't talked about. Urine chart color, first thing in the morning can help. During the day, it doesn't make a difference. It can be very invalid, but first thing in the morning, if athletes look at their urine color and it's between 1 and 3, then they're adequately hydrated. If they're between 4 through 6, they would be moderately dehydrated, and 7 through 8, you really don't want any depending water coming out of there. So if that happens, then you really need to get the athletes to hydrate. You might even try to implement some sort of policy where if they are hypohydrated, then maybe they don't practice the same as other players. That's the easiest and most effective, cheapest, easiest way for an athlete to recognize because they can do it on their own. The other 2 ways to recognize hydration are specific gravity, and that one, most of you will probably be familiar with drug testing. You can do specific gravity by just taking a little urine sample and then putting it onto the spectrometer refractometer, and as long as it's above 1.02, or if it's at 1.02, then they're good. If it's above that, then they're going to be too high a concentration of salt in their urine, so they have to start drinking. And the blood is pretty impractical. The last practical approach to assessing hydration would be patches. Gatorade has a couple of these. There's other forms. Obviously, you can buy the expensive stuff or you can buy the cheap stuff. But ultimately, the sodium content won't necessarily be assessed properly, so we'll go over that in probably about 2 or 3 minutes. I would say that the patches wouldn't be extremely successful in educating the athlete, and we'll go into more details. The best way possible is to do a whole body wash down. As you can imagine, athletes doing this process at the beginning of the season, and then in the middle of the season, and then at the end of the season, or even just after a regular workout, collecting all of the sodium that comes out of your body, and then trying to calculate that into an appreciable amount for regular everyday life is kind of hard. So the best clinical method without doing that entire process would be to use an iStat, and it's right. So that device on the top right is the iStat machine. I don't think that anybody's going to be affording that at their high school or even at college, unless you're a research institution. So I guess that wouldn't be helpful. And then the last one is the patch. There's a lot of variability. I gave you guys a handout, and at the back of the handout, there's the last page is a diagram, and that was a study done by Baker in 2017 to show the sodium concentration and the differences between people. But it also, there's another, there should have been a second part to it. I think I might have to email that out after this lecture. There's a second part to it that shows the different devices, and the sweat patches are really, they vary a crazy amount between where you place the patch, with the armpits and other body joints will be better to assess, but they're going to be a little bit higher concentration sometimes than what the body is actually dispelling, versus it being that forearm. So the forearm is actually the best place to put it, but that's going to be making contact with patients a lot when they're playing sports. So it's not always useful except for endurance rounds. The validity of the devices is pretty well known for sodium content, but it's not very well used. So I would encourage you to try to get the patient to just make sure that they're not chronically depleted of all of their sodium, and then try to make sure that they're on hotter days or days where you think that they're going to be perspiring more. Make sure that they're supplementing afterwards. For the equipment of all of these, I just wanted to put a little quick blip in there of the type of money that people would be spending. The rectal thermometer would be the ideal for thermal measurement, but some people don't want to use it in a regular everyday setting. So if you can get a thermistor, it's not very expensive. It's like $25 to $30. The actual measuring device is a little more expensive, but the thermistors, you would just use one per person. You can't use it for multiple athletes. That's kind of gross. You could, I guess, just keep washing it, but most people would end up using different ones. So That one's the best possible way to measure temperature, and if you can get it, that would be the best. Oral, temporal, those are all very cheap, and it's not inconceivable to use, but they're not very reliable. So the pill is the last one, that one on the top and the very bottom. I think I said for about $1,000. So in reality, you probably won't be using that. For the iStat, again, like I said, it's super expensive. We're probably not going to use that, but that's what they would use in the hospital or if they were in the EMTs. So EMTs would use that to assess. The other equipment that you'll need is the ice tub, and you're going to need some ice and towels. The towels in this case could be used to dunk, and we don't really like to do that for the cooling of heat illness, but if you can use them to try to stir, then that would be helpful. And you can also put it underneath their elbows and their armpits to try to help push them up so that they're not falling into the water. So it would be useful. A scale will be useful for trying to help assess how much water is lost before and after activity. And then the well flow temperature is one that we'll talk about in a second, and that's on the prevention side. Those are other equipment that you'll use to try to assess the ambient temperature and the environment to figure out what you want to do for alcohol activity, which is part of the MIAA regulations. So we'll go back to that in a second. Prevention for you guys is going to be the best way to stop heat illness, and education is number one. So if you can get them to calculate their sweat rate, and they're going to be able to change their everyday activities to make sure that they're hydrated on a regular basis, or at least minimally hypohydrated. Drinking, there's a handout that I gave you guys. You can use that to calculate the sweat rate, and that's from the Corey Stringer Institute. The KSI is a pretty good avenue. So they have a lot of information on that website, and that's through UConn. So if you want to go on there, you can find pretty much all of the information that I was talking about, and maybe even more studies. But I would look at the position statement that 2017 came out, and that one's the NATA position statement on fluid replacement for physically active. You want to make sure that the patients are acclimatized, and it takes about 10 to 14 days to acclimatize to make sure that it's the same temperature, or at least similar temperature to the temperature they'll be performing activity. Their salt levels aren't, like I mentioned, aren't really possible. The level of confidence from this package isn't really good. So I would probably just try to make sure that they replace as needed. The terrain is something that you want to consider when you're putting together the replacement plan and the prevention of heat illness. So if there's a hot day and you're on AstroTurf, make sure that you're incorporating that idea into your guidelines for your athletes. And then the gear matters in sports where you're wearing a lot of stuff. In hockey, even though you're on the ice, you're going to be retaining a lot. There's plenty of studies out there. You probably look through the KSI website as well to see some of that research. But heating with equipment on is a huge issue. And you want to make sure that you're wearing something that's going to regulate your sweat. That helps at least to minimize the latent heat issues. And then the availability of water is huge. Most people aren't really able to drink while they're performing activities, so it comes down to how many drinks they have. And in a second, we'll go over those MIAA regulations. And then the intensity of the exercise should be similar to what you're experiencing on the field, so that you can calculate from that point forward how much extra water you have to give on maximal effort days. You want to make sure that you recognize that there's like a 2 to 3 week window for your sweat rate to change. So if you did something, like I said, 2 weeks later, 3 weeks later on in the season compared to preseason, it's going to change. So you might want to consider repeating it as the year goes on. That's pretty easy to do if you do an early warning thing with your teams. So I would try to just incorporate that every once in a while, at least quarterly. The diet matters, so you want to make sure that the athlete isn't just eating sodium nonstop. You want to make sure that it's a balanced diet and know the effect of the medications. But the action that you guys can take from this point forward after today would be to update the EAPs to include the regulations from MIA, which we'll go over in a second, fluid replacement plan, and then if there's any lack of equipment that you need at your high schools or colleges, I would make sure that you can at least get some of those tools. The cold tub is not very expensive. Everybody can have it. It's usually an issue more of storage for the sports, but I'm sure that you can find a place outside, some baby shed that you can store it into. It really isn't. It's not a big expense, but most people forget that it needs to be there on some of those impromptu practices. So I would try to go back over that with every coach and make sure that they know that every single practice they should have access to that tub. You should try to hold in services with your coaches and the beginning for your teams themselves at the beginning of the season, so they're all aware of the effects of hypohydration, overheating, and those other issues. And that's a good time to explain that if anybody does have sickle cell trait, maybe they can talk to you in private after that meeting, so that you can immediately know from that if you missed it on the pre-season evaluation. And then the last thing is to change the school policies. That's the things that you can do right before the season, big picture stuff. You want to make sure that they have the right policies in place for the order of operations to make sure that you cool the patient before you transport. Another thing that I thought was helpful when I was working at colleges was to put bathroom flyers up for the hydration status. So I would do that a lot and make sure that the athletes know again that it's the first morning, you're in color that matters more. So in the middle of the day, it might just be an indication that they've recently ingested a lot of fluid if their water is clear. But anytime it goes lower to the 7 or the 8, that's a very, very bad sign. I included on here the KSI website. You can see on the right, there's a high school policy assessment so that you can try to figure out if your policy is up to par. So I'll try to check that out if you get the chance. There's also a course that you can try to put your coaches through. And then there's a bunch of research. If you go into the I put on here the link to the MIAA heat policy, which is coming up. And the regulations just changed at the beginning of this year. I think it was instituted June 1st. Everybody should follow this. So if you don't have wet bulb low temperature, then you're technically putting your patients at a disadvantage, and you're not in compliance with the MIA standards. So if you can't have the wet bulb low temperature, which the $450 Kestrel one, I don't know if it's necessary. You can use that $150 wet bulb low temperature. That's pretty reasonable for most schools to buy, at least if they're preventing a $1 million case settlement down the future. I would try to get them at least to get that one. I've used it in practice a couple times, and it seems like it's pretty close to what it lines up to online. But you can also look online to see what the temperature is for wet bulb low temperature on a couple different websites, and mostly the National Weather Registry will be the best. But the regulations for masks, as you can see here, basically the first wet bulb low breathing, anything under 76 degrees is going to be very easy. You can do whatever you want. If it goes up to 81, then you should try to give a couple breaks. If it goes up to 84, then you should start giving more breaks, and you shouldn't compete past 2 hours. And then the last one, if it gets up to 84.1, then you need to really monitor all of the guys. At that point, the athletic trainer should be on the field, or whatever field that is, that's still going if they decide to go, still go. And you have to make sure that there are 20-minute breaks for every hour of activity. At 86.1, you can't compete. You have to just stop all competition. So I almost got up to 86.1 in the middle of September, believe it or not. And that one was hot. We had pretty much all heat cramp episodes. I think there was one syncopal episode. But we want to really make sure that that's enforced, because that's the driving factor for our state. Here's some of my references, and I have a couple other links in case you needed to look at some of those other items that you can buy. So the level of low temperature is on there if you want to use this link up to this point. The ACE hardware side is on there, and then the iStat, which is 14 gram if you want to buy that thing. So in conclusion, we should try to make sure that athletes, first of all, we need to be able to assess whether people are undergoing a heat illness versus generalized tired feelings. If they're starting to go in between a hyperthermic episode and a hyperthermic or hyponatremic episode, then you need to be able to differentiate between the two, and it's always better to cool first for both of them and wait until the EMS gets there. If you get the temperature while they're in the tub, then you'll know whether it's either heat illness or if it's hyponatremia issue. And then after you're done with all of those things, you have to go back and revisit any of the policies that you have for your athletes to make sure that your policies are up to date and measuring compliance with standards. The fluid replacement plan is something that is individualized. It differs between every person, difference between every setting that they're in, and a difference between themselves, even at the beginning and the end of the season. So make sure that you're keeping that up to date for athletes. Pretty easy thing that they can do on their own as long as you set them up with the right knowledge. So education is key. And if you have any questions, please don't be afraid to ask, but there are also a lot of other resources on this website, like the NSI website. And I might be a little biased, like I said at the beginning, because I did a lot with them in undergrad, but I think that everybody could agree that they're one of the leaders in the nation on heat illness. So I would really look at that information. But don't take it with a grain of salt. Anybody have any questions? Yes.
Does this change like altitude wise, like like issues like heat illness and stuff like that? So it's not like up in Colorado. Does this water warmer?
I would put it back to the oxygen level. So if you've already acclimatized yourself to that area, then you should, in theory, be able to thermoregulate the same. But if you're not used to that hypoxic environment, the higher that you go, your body's going to be working harder to get the same amount of blood to your blood to that whatever that muscle group is. And the harder that you work, the higher the lactic acid buildup, the higher the core body temperature. Because you have to increase cardiac output. So I would say that the higher that you go, as long as you're not acclimatized, it would be higher, but if you're acclimatized, then it should be. Yes.
You need to ask or look, and I haven't found any, but maybe you know, have there been any studies of infrared thermometers using the back of the foot?
I don't know. I didn't encounter any, but that doesn't mean that they don't exist.
Yeah, I did like a Google of them ones who do it.
I know some good people who would know that information, so I'll definitely just give me your email at the end of this, and I'll definitely do some research. I don't know offhand, but it wasn't talked about in any of the recent position statements, and it wasn't mentioned. Not like any of the 14 or 15 studies that I looked at when I was doing the presentations. So I'll have to look at that, but I can definitely get back to you. Yes.
You mentioned putting nice towels in the place.
Yeah, sure. It's not the best way to cool athletes, so I didn't really go into too much detail, but if you're going to put ice towels on people, you want to make sure that it's over the areas that are most, that the blood vessels are most exposed to the skin. So the top areas of the popliteal, I mean the femoral artery, you're going to try to get. You want to put it on the front of the thighs. If you can do the antecubital, that would be great. Axillary is pretty good, but the head and if you put it around the neck, the top of the head, and then over in front of the thighs, that would be the best. If you can cover the whole body, the more coverage that you get, the faster it goes. But you still have to make sure that you keep changing out those towels like every 2 or 3 minutes. So you would be pretty much constantly dumping and then replacing, and then move on to the next one. Most people, I know that there are some things like those mission towels that came out where if you snap them, then they turn colder. If you're trying to use those, the cold difference isn't actually cold, it's more just a sensation. So, I mean, it's not it feels great for the athlete who's maybe a little bit heat exhausted, or if they have a syncopal episode, then that can make them subjectively feel better and come to a little faster just because they get the rush from the cold. But it's not very effective in trying to decrease core body temperature. So it would really just be decreasing that area. I wouldn't, the admission towels aren't better at cooling than others. Yes.
When you talked about hypernatremia, you mentioned that under 135 millimoles was concerning. What's the normal range?
I love about 135. It's supposed to be between 135 and 150, I think. But if you have any athlete who's experiencing the symptoms, then they're going to be below that 135. Unless they're experiencing some other type of heat illness, obviously. And there's a lot of overlap between the two symptoms. So if you can prick somebody and get a blood sample and then do the optionality that that's, then that would be great. But I would feel more based on symptoms and then try to rule out big illnesses before you worry too much about that. They're going to do all that stuff once the illness arrives. And most of the time, I don't know how many athletic trainers have their phlebotomy license or certification, but I don't think most of you guys are going to be doing IVs. Well, unless they have a pick already in, or they have some sort of IV already, then I would probably just try to communicate with EMS what you think the issue is and get as good of a history from the athlete as possible, because they're going to tell you if they've been drinking. I mean, if they're unconscious or if they have severely altered CNS dysfunction, then they're not going to be able to display that. But hopefully they're on the more mild end, and you can ask them if they can give you how much water they drank that day, if they've had any salty foods. If you have to try to be able to get. I think most of the time that what you don't want to do is you don't want EMS to be giving a normal saline solution, because that doesn't do anything. It doesn't give them more sodium at all. It just gives them the same exact dehydrated state of fluids back in. So yes, in general, it would be helping with blood volume, but it wouldn't be helping with the temperature. So I try to ask as many questions as possible.
Question about EMS.
Yeah.
Have they gotten any better about education with this and carrying things like rectal thermometers? I know that was my first real experience with where I needed to call EMS.
I would just try to keep it on your own. Nobody wants to do them. So the people that it's going to be more of an issue with are the people who are still somewhat with it and they kind of know what's going on, kind of like I was when I did my study, because I was kind of fighting and saying, no, I'm fine, I can keep going. But if you're not conscious, you're probably not going to put up much of a fight about it, and then it just comes down to your medical opinion. And you're the one that's controlling the situation until EMS arrives. And when EMS arrives, it's still up to you to control that situation before you feel comfortable to send them off. If you know for a fact that they're hyperthermic and they need to stay cooling, they need to stay cooling before they do. You need to put your foot down saying, you're not taking this athlete. If you don't have the temperature regulation device, what I would do is just put them into the tub and then cool them until they start to shiver. They're going to start shivering at 95 degrees, and 93 degrees is hypothermia past the point where you would want to get to. So if you start to see them shiver and they're still unconscious, that means that they're cooled down to a point where they're definitely not hypothermic. So I would just dump them in the tub until you know for a fact that they're good to go. If the rectal is there, then that's the best assessment. You just need to get them back down below 101. Yes, sir.
Yeah, I mean, that's the issue. Just started getting into the issue of EMS and whether it's a contract service, fire department, whatever it may be in your town, at the school you're at, because they're going to come in and want to take the athlete and go.
Yeah.
And then you have to have them stay there and treat them until you feel they're down 102 and you're out and they're somewhat alert and ready to go. So, I mean, that's going to be a conflict. So that's something you should address, before the season.
Right.
Work with your EMS and talk about it. You give the examples in terms of Boston Marathon. And, we had the same issues all the time until EMS realized and the literature proven that they have to be treated on site until they get down to at least 102, and that they're stable. And as well as educating all the EDs along the route and dropping off tubs and thermistors at each hospital along the way.
Yeah.
And each site along the course, so that the understanding is the treatment is taking place. So it's a conflict that you should address right up front with them. If they're calling them and say, well, he needs to cool more, or she needs to cool further until we can, transport.
Yeah, that's a great point. If you, at the beginning of the season, that goes back to trying to establish at the beginning of the season your policies as a school and your policies potentially with EMS, because they're part of that EAP. So you have to update the EAP based on our standards. And the EAP should include that. And if it's already written, then they should just follow your direction because you already have your written EAP. But if there's a pushback, then you need to put your foot down in that moment and keep cooling until they're good to go, because you know that they're not hypothermic and they're not still continuing to break down parts of their body at that time. If they go, if they're really giving you pushback, you can tell them the symptoms and explain that if they continue to stay hypothermic, they're going to be in more of a dire strait than when the EMS arrived, and they obviously don't want that either. It's kind of the same as, the handoff is when you're doing a cervical spine stabilization and EMS arrives and they are just about to slap that collar on and then lift them up. Like, you still kind of need to make sure that you're there, even though they just arrived and they ask you, all right, we're good to go. You need to stay there stabilizing that C-spine until their collar's on and until they're lifted onto the plate. So I would try to make sure that you don't push over. And that's one of the hardest things. And hopefully you've already cooled for long enough where they're cool by the time they get there. But some in our areas, like EMS could be there in 2 or 3 minutes. So it kind of depends on how much of a pushover you are, and you need to put your foot down for the athlete because you know what's best.
And there's plenty of literature that you can provide for them.
Right.
In advance. So that's another thing. The other thing about parents, or depending on high school, college, is consent forms to allow them to use rectal therapy.
Yeah.
So that you get them in advance and get that set up so that, the controversy or the blowback from parents and so forth on those issues could be significant.
And you could work that into your preseason policies and procedures. And if you tell athletes at the beginning of the season, during your meeting with them about fluid replacement and all that stuff, and telling them that the reason why we're doing this fluid replacement is to prevent heat illness, if you tell them at that point that the best practice is to use rectal, and it's not about whether you want to or not, it's about whether you live or die, that will scare them enough to make them understand that once you get to that point and you're suggesting that they use it, that means that it's a real deal. I don't think most athletes would give you pushback unless they were experiencing the confusion and all that other stuff that you would already be just pinning them down and telling them this is what we're doing. Anyway, I would. It's harder when you're when you're working with kids because you have to make sure that there's still privacy. So if you're going to be removing them from play, make sure that when you're removing them from play, you're already going directly back to wherever it's best to do that rectal, because that's ultimately, you're not going to want to stop and then say, oh, okay, we're recognizing heat illness. Let's say that now we think that it's heat stroke instead of heat exhaustion, and then try to move again. Just go in one fluid motion right off to a shaded area where there's a little bit of cover, either from trees or like hold up a towel or something to cover them over.
You have to plan in advance. Like under 18 years old, you need to have that. So, yeah. You can tell them that they agree that mom and dad.
Any other questions, guys? Yes.
I have a question, but don't feel like you have to answer it now. You can others.
Okay.
I have a question about the tradition of using sauna and then jumping into cold water. So that transition from hypothermic, and if it does affect how health benefits, or if it isn't that just for
Doing a contrast bath is, a lot of people do it, and you don't necessarily become hyperthermic.
but that's what I'm talking about.
But if you do,
Yeah.
if you do get up to a point where you're experiencing hypothermia, I don't know is it managing Could you just repeat the question?
Yeah, so my question is that transition from, say, like people, so there's no retro and there's not. Right?
Yeah.
So, we just onesies to hit that, the.
Yep.
Jesus, but, 112. And then down into 55-degree water. So, we were kind of just debating back and forth about whether that actually is beneficial for your physiology, or if that's just like your physiology dealing with it. Trying to just fix about whether.
The transition doesn't matter
Okay.
at all. It doesn't matter in any way, shape, or form if you're starting to vasoconstrict on the periphery, because ultimately you're already dispelling so much heat out that you can't actually evaporate, that you need to get as much fluid, as much heat dispelment through the changing of the waters as possible. So it doesn't, that athlete's not gonna feel that it's cold. They're gonna feel that it's a relief because they're overheated and they need to get down to a temperature where they're able to function. Their body's not gonna, they might feel a little bit of a shiver, but that's not gonna, you're not gonna see the shiver. It's just gonna be a little vasoconstriction at the periphery. And from that point forward, it loosens up. When I went into the water, I didn't feel cold at all. It's the shock, like when you're not having CNS dysfunction and when you're not having hypothermia, that you're gonna feel. Like you're gonna feel it if you're at 101 or 102 or 104, you're gonna feel the cold water if you're not already in a thermoregulatory emergency. You're just, they've already said in the literature that I can go back to, I would probably look at the CASA 2010 immersion in cold water. That's number 3 on my references. I would look at that one because they talk specifically about the shiver response when you get in versus vasoconstriction. And you're already going to be, there's a lot of areas of your body that could have that initial response, but after about 30 seconds, it's.
So that study is actually kind of where I started. So
Yeah.
because it doesn't say whether that your ability to physiologically adapt faster, better, whatever, is actually beneficial or not. So like, for me, I'm not necessarily speaking of athletes in general, but you know, the 40-year-old who wants to prove that he's guys get up to 120 jumping for a win. Like you know, he's convinced because it's finished, that's the way you should do it, and I'm convinced that because he has a cardiac condition, he's gonna kill himself. So
Okay, so yeah, going into cardiac issues.
yeah, so yeah, we don't have to answer that right now, but
Yeah, I mean, have an AED on standby, I guess, but you should do that anyway. But it matters more to get the body down because if you don't, if their heart stops, you can keep it going. But if your body is starting to break down, like from the lipid membranes of all of the areas, like you're not, it doesn't matter if you're having a cardiac issue if your brain's dying.
I think that's a wonderful conversation that we can continue in the reception after the lecture at 3 o'clock. I would be very interested to speak more about that. We're going to take a couple of minutes and get Katie set up, and if you're thirsty like I am, we can still grab some drinks after hearing all about dehydration